This is Section 2 of the 2017 Wisconsin HIV Surveillance Annual Review webinar. This section will address new HIV diagnoses among Wisconsin residents during 2017. This figure gives the historic picture of the HIV epidemic in Wisconsin. The figure shows the number of Wisconsin residents diagnosed with HIV infection each year, from the first diagnosis in 1982 through 2017. Diagnoses rose rapidly during the 1980s until peaking around 1990, and then declined until the late 1990s. Despite more diagnoses in 2017 compared to 2016, both the number and rate of new HIV diagnoses have declined over the past 10 years. This figure shows the trend in the annual number of new HIV diagnoses, shown as the blue bars, and the HIV diagnosis rate, shown as the purple line, in Wisconsin, between 2008 and 2017. There were 259 new HIV diagnoses among Wisconsin residents during 2017, at a rate of 4.5 new diagnoses per 100,000 population. The number and rate of HIV diagnoses among Wisconsin residents has declined since 2009. Between 2008 and 2017, the number of new diagnoses ranged from a low of 221 to a high of 282, with an average of 242 new diagnoses per year. The HIV diagnosis rate in Wisconsin is low by national standards. Wisconsin, shown in red on the graph, ranked 8th from the bottom during 2016. However, we know that rates are higher within certain geographies and populations. Wisconsin's HIV diagnosis rate is about 3 times smaller than the nation as a whole, which is shown in yellow. Wisconsin also has a lower diagnosis rate than its Midwest neighbors, which are shown in green. Knowing where people receive their HIV diagnosis helps us to understand testing patterns and subsequent linkage to care for people who test positive. During 2017, the most common settings for HIV diagnoses were outpatient clinics, 43%, inpatient hospitals, 13%, counseling, testing, and referral sites, 11%, and health departments, 10%. This figure shows the number of new 2017 diagnoses by gender identity. In 2017, there were 6 times as many males diagnosed with HIV compared to females. This figure shows trends over time in the HIV diagnosis rate for males and females in 2 age groups, ages 13 to 29 and ages 30 to 59. The rate among males ages 13 to 29, shown in solid blue, increased from 12.4 to 17.6 per 100,000. The rate for males ages 30 to 59 fluctuated, shown as the dotted line in the middle of the graph. The diagnosis rate also declined among older females and fluctuated among younger females. This figure shows the number of transgender individuals diagnosed with HIV over the last decade. The term transgender refers to people whose gender identity does not conform to their sex assigned at birth. It includes people who self-identify as male to female or transgender women, female to male or transgender men, and many other gender nonconforming identities. A transgender person may have the anatomy of their sex at birth, the other sex, or a combination. Gender identity and sexual orientation are separate, distinct concepts, with gender identity referring to an individual's sense of themselves and sexual orientation referring to an individual's attractions and partnering. A total of 56 known transgender individuals have been diagnosed with HIV in Wisconsin since the beginning of the epidemic. While the data collection of self-reported gender identity has improved over time, this likely underestimates the true number of transgender individuals diagnosed with HIV in Wisconsin. Of the 56 known diagnoses among transgender individuals, 40 occurred between 2008 and 2017. Of these, most were from a racial minority group, most were under age 30, and most were attributed to sexual contact. This figure shows the trend in the percent of new diagnoses each year among whites, shown in green, compared to people of color, shown in blue. In the 1980s, the majority of new HIV diagnoses in Wisconsin occurred among whites. Since the early 1990s, the number of diagnoses among racial and ethnic minorities has exceeded that in whites. During 2017, the majority of individuals newly diagnosed with HIV were members of minority racial or ethnic groups. Yet racial and ethnic minorities made up just 17% of the state's population. This health disparity is not due to innate biological factors. Rather, one's determinants of health, such as poverty, unequal access to healthcare, lack of education, stigma, homelessness, and racism can disproportionately affect persons of color and can put individuals at greater risk for acquiring HIV. The HIV diagnosis rate further highlights the disproportionate impact of HIV on racial and ethnic minorities. Black males are 13 times more likely to be diagnosed with HIV than white males. Similarly, Hispanic males are 5 times more likely, and American Indian and Asian males are 2 times more likely to be diagnosed with HIV compared to white males. Although the number of females diagnosed with HIV is much lower than males, the racial and ethnic disparity is greater. Compared to white females, Black females are 21 times more likely, and Hispanic females are 5 times more likely to be diagnosed with HIV. The number of Asian and American Indian women diagnosed with HIV over the last 5 years in Wisconsin is too small to publish rates. The number of American Indians and Asians diagnosed with HIV in Wisconsin is small, and therefore these groups are often left out of figures and graphs showing the HIV epidemic by race and ethnicity. The next 2 slides describe the HIV epidemic in Wisconsin among American Indians and Asians from 2008 to 2017. Of 14 American Indians diagnosed with HIV during 2008 to 2017, nearly half were under age 30 at the time of diagnosis. Most were diagnosed in the southeastern and northern regions of the state, and most were attributed to male-to-male sexual contact. Of the 55 Asians diagnosed with HIV in Wisconsin during 2007 to 2017, 40% were under the age of 30 at the time of diagnosis. Most were diagnosed in southeastern and southern Wisconsin, and half of diagnoses were attributed to male-to-male sexual contact. 2% to injection drug use, and 16% to heterosexual contact. 1/3 of all newly diagnosed individuals had unknown transmission risk. The next few slides will be about the most likely risk factors associated with HIV transmission. This figure shows the adjusted risk for Wisconsin and for males and females separately during 2017. Please view the Data Concepts module of this webinar series in order to learn more about adjusted risk. In this webinar, MSM, or male-to-male sexual contact, includes men who report ever having sexual contact with men or both men and women, including those who also injected drugs. Injection drug use includes people with injection drug use risk, excluding MSM who also injected drugs. Heterosexual contact includes individuals who report heterosexual contact with a person known to have or to be at high risk for HIV. The overall risk profile for 2017 was 72% MSM, 15% heterosexual contact, and 9% injection drug use. Among males, 87% of all diagnoses were attributed to male-to-male sexual contact. Among females, 80% of diagnoses were attributed to heterosexual contact and 20% to injection drug use. This figure shows the trend in the number of new diagnoses between 2008 and 2017 by estimated transmission category. The estimated number of new diagnoses has been stable among MSM, shown in dark blue. Diagnoses attributed to heterosexual contact and injection drug use have declined. For providers of prevention and testing services, it is important to know the ages of people for targeted messaging. One common age metric is median age at diagnosis. Median age at diagnosis is the age at which half of people were older and half were younger. This graphic shows the median age for all people diagnosed during 2017, the three major risk groups, and MSM by race and ethnicity. The median age at HIV diagnosis during 2017 was 31 years old, with variation by transmission category and within transmission category. The oldest median age at diagnosis was among people with a history of injection drug use at 44 years. The youngest median age was Black MSM at 26 years. While the overall number of diagnoses attributed to male-to-male sexual contact has been stable, there have been changes among some groups. This figure shows the trend in the number of new diagnoses between 2008 and 2017 for MSM under age 30. While the number of diagnoses in 2017 was less than during 2016, there has still been a statistical increase in HIV among young Black MSM over the last decade. While the number of diagnoses among young white and Hispanic MSM was greater in 2017 than 2016, there is no statistical trend over the last 10 years. During 2008 to 2017, there were 205 infants born in Wisconsin or whose mother was a resident of Wisconsin who were exposed to HIV through childbirth. Of these infants, 98% are HIV negative, 2% are living with HIV, and 1 has an unknown diagnostic status due to the recency of birth. Nearly half of all individuals living with HIV in Wisconsin currently reside in Milwaukee County. 12% live in Dane County, and 4% each live in Racine, Kenosha, and Brown counties. According to the CDC, late diagnosis occurs among individuals who progress to stage 3 HIV or AIDS within 1 year of receiving their initial HIV diagnosis, including those who have progressed to stage 3 by the time they are first diagnosed with HIV. Stage 3 HIV typically occurs 8 to 10 years after acquiring HIV in the absence of treatment and is based on very low CD4 count and/or a stage 3 defining opportunistic infection. Early diagnosis is thus important for both optimal health outcomes for the person living with HIV and for reducing the risk of further HIV transmission. The percentage of people diagnosed with HIV in Wisconsin who had already progressed to stage 3 by the time they were first diagnosed with HIV, shown in blue, declined from 31% in 2012 to 17% in 2017. This may reflect, in part, a 2014 change to the stage 3 surveillance definition, in which individuals with a stage 3 defining CD4 count less than 200 are no longer designated as having progressed to stage 3 if a negative HIV test in the previous 6 months has been documented. Instead, the low CD4 count may reflect recently acquired HIV. Individuals may be incorrectly classified as having progressed to stage 3 if the recent negative tests are not documented. Collection of recent negative tests has improved over time. The percentage of individuals progressing to stage 3 within 1 year of HIV diagnosis, including being first diagnosed during stage 3, or the total of the blue and purple bars, declined from 39% in 2012 to 17% in 2017. This ends section 2 of the webinar.